more and more people are thinking about ways to combine physical activity and exercise with other treatments because that specific use of exercise with the therapist that and trying to unlearn things, that's one potential role of physical activity. But obviously the therapists have other arrows in their quiver to try, and so there's a lot of ways that things potentially can be combined fruitfully that we really haven't studied well yet. I do know there are some studies that showed promise where they combined exercise with cognitive behavioral therapy and showed some benefit there, right? So you've got evidence for cognitive behavioral therapy, you've got some evidence for physical activity, and then maybe that combination, at least for some, will even bring better relief with fewer, you know, residual symptoms and problems.
Yeah, and it's interesting as well, actually, as you bring up that point. When we're taught to use exercise in therapy as part of exposure therapy, it's not really talked about as exercise. It's more, this is a form of exposure therapy. So there still seems to be a bit of a hesitation, and I'm really interested in the implementation gap. You've referred to a ton of that there is a ton of evidence for the support of exercise for use, particularly with depression, but also some meta-analytic evidence with anxiety disorders. But I'm still seeing a lag in terms of actual practitioners using exercise.
Yeah, well, I think a big part of it is probably just training and interest, right? So, someone like me, I got into the field of physical activity sciences because I loved to be active growing up. I loved to participate in sports. I had a little bit of success, so that was also, a reason for me to love it.
What's your
And
sport, Pat?
well, several things. I mean,
Yeah.
like growing up, I loved kind of the traditional American sports of baseball and football and basketball, and
Nice.
those can be kind of rough when you get older. But I've been a
Yeah.
long-term runner, and then more recently, like around pandemic, I got a mountain bike, so I've been doing that,
Cool.
and trying to do some weightlifting regularly. As you get older,
Oh,
you got to keep some muscle mass and everything.
yeah.
Uh,
Nice.
yeah, and then jog with the dogs with a friend of mine, and so trying to stay
Jeez.
active.
Doing
Um,
everything.
but well, not everything, but I'm happy to move around.
Yeah.
But all right, so where were we? Taking me off
uh,
the.
Implementation gap. Practitioners not
Yeah,
using exercise.
yeah. So someone like me, trained in exercise science, and we just focus on that all the time. That's our lens. And then you have people, either say psychiatrists or psychologists. That's not their lens at all, and so their training, they don't, generally speaking, get much detailed information about exercise, and so then you get done with your training, and here are the things that we have evidence that work, and here's your role within all the possibilities. So if you're a psychiatrist, you're giving drugs, generally speaking, and if you're a psychologist, then you're using a range of cognitive and behavioral techniques. And so, um, like, take psychiatrists, they they make money by serving people through medications there where there's evidence to support that they would be useful. Now they're going to not do that and just say, "Hey, why don't you exercise?" And some of them will combine it, combine things. But unless they have that personal interest or professionally they've been exposed to it and they like it, then I really think that's a big part of the reason why there's maybe a gap and fewer people use it. Of course, going forward, I think there's a chance that there may be more and more cross pollination between these areas, and with the idea of a precision medicine, that might help. So, my take on that. It's like the Star D depression study. Have you heard of that Star
Mm,
D depression
yes.
study?
Biggest
So,
antidepressant trial in the community.
right. And so, but one of the things they did was for people who were non responsive to their first treatment, they then were switched to a different one. And then some were switched to exercise as one option. And so I think in the end, probably what will happen is that ideally, eventually we would learn that some people really respond to one kind of treatment, the SSRI, let's say. Someone else really responds well to cognitive behavioral therapy. And there'll be a subset that respond really well to exercise. And then I think there's combinations that also ultimately, we're going to give you walking for 20 minutes, 3 days a week, 5 days a week, or whatever, and you'll get cognitive behavioral therapy. And for you, those things really help, you know, treat your anxiety problem in this example. So, and then as other people get the same treatment, those two treatments, they get nothing or next to nothing. And then maybe the medicine works for them, right? So, because of, I think, the variation in our biology as well as our circumstances and our sociology and our friends and family, all those kind of things that change how people might respond, uh, none of these treatments work always equally well for everybody.
And I think a lot of that comes down to, right, the fact that two people can have a mental illness, let's say depression, for example, but vastly different symptom presentation. And there's hundreds of combinations of
Yeah.
depression you can have all falling under the same umbrella of major depressive disorder, but different symptom presentation. So it makes sense mechanistically that different treatments would work for different people, given they're not actually the same mental illness.
Right. And on the mechanism side, another way to think about it, expanding on what you just said, there may ultimately be a limited suite of pathways or mechanisms by which people can improve their symptoms or ultimately get some kind of relief. And so even though there's hundreds of combinations, like you say, and if you go to the biological level, there's thousands of genes that can get turned off, or turned on that might be relevant. But in the end, maybe there's only 10 or 12 final pathways by which things change. And right now, we don't know precisely exactly what those are and how they combine to give us the change. I still think things are a little, broad and general in terms of the mechanisms, just because the brain is so damn difficult to understand.
Yeah, yeah, yeah. And I suppose on the way of prescribing, you talked about medication versus exercise. I'm not sure in the States what it's like, Pat, but here in Australia, it's really pleasing to see exercise has been included in national uh, treatment guidelines for things like depression, for people with mild and to moderate depression. Exercise is now is recommended as a first line treatment, at least as an adjunct to medication, by this is like the Royal Australian College of GPs or physicians equivalent and Royal Australian College of Psychiatrists. So big leading national bodies recognizing some of this evidence, and it's slowly filtering through. But when I talk to doctors, even psychologists, a lot of the barrier for them is okay, that's great, but what exercise, how much, all those moderators, and a lot of them, understandably so, are steering clear of prescribing exercise because of the uncertainty of how much, when, what type. So it's a really interesting dynamic that's evolving, and I'm curious to hear your take on it.